Yes, now. Good morning, everyone, and hello. Welcome to today's edition of Patcast, and good afternoon to those in Latin America, those who are watching from Brazil, and good evening to those who are in other parts of the world. And I'm Rifat Manan in California. Today is August 19th, 2025. So it's another Tuesday for our regular podcast session. And our guest today is going to be Dr. Felipe Dalmeida Costa, who is a pathologist at AC Camargo Cancer Center in Brazil, and who is also a coordinator of pathology education at DASA. And he also serves as secretary adjunct at Brazilian Society of Pathology. So he's an eminent neuropathologist, and he takes a lot of interest in pathology education. And we are very delighted to have Dr. Dalmeida with us today. And today he's going to talk on DNA methylation profiling for CNS tumor diagnosis. And thank you, Dr. Dalmeida, for joining us today. Over to you now.
Thank you so much, Rifat, for this kind introduction. And thank you very much for giving me the opportunity to give this talk and podcast, which I follow since the beginning. And also thank you for giving the opportunity for other Latin American speakers to present their works here at Pathcast. So today we're going to talk about DNA methylation profiling for CNS tumor diagnosis. We've been doing that in Brazil since 2021, and I'm going to tell you the history of methylation profiling and how it works, and I'm going to tell you based in a case-based manner our experience here in Brazil. So these are my disclosures, but doesn't interfere in this presentation. And since we are most used to next generation sequencing panels, I'm gonna give you this introduction so you can understand a little bit more how the methylation profiling influences in our biology and also in our tumor biology. So let's imagine here that we have 4 different organ types from the same person without any genetic diseases, and then we have kidney, we have liver and pancreas and also brain. So let's take a piece of tissue and extract DNA, and let's perform next generation sequencing wherever, if you want to perform a panel, large panel, exome, or even the whole genome sequencing. So what's the genomic difference between the different organ types and different cell types from the same person? There's absolute no difference. So how we can have so many different cell types with different functions if we have the same DNA code? It's because we have other mechanisms that regulate the gene expression profiling, and one of the main mechanisms is the methylation. So methylation is a tale also of cell of origin, because we don't need the same genes for each cell type. So a neuron depends on some configuration of active and inactive genes, which is different from a liver cell and different for a keratinocyte. So we can track the origin of some tumors by looking at the different methylation profiles they have. It is like a 0-1 binary code. So we can have different cell types like respiratory epithelium and neurons. If you perform the karyotype, it's going to be the same. If you do the sequencing, they're going to have the same DNA sequence. But what's the difference is that what positions are methylated and unmethylated in their DNA. So we can apply this concept with a molecular array with almost 1 million probes of methylation, and then we can employ that for research and also for tumor diagnosis. And the same concept can be applied to CNS tumors and other tumor types, but it started all over with CNS tumors. So here we can see 4 different tumor types from usually young patients, but all of them under the microscope have a very similar morphology. They can have these small round glial cells with glio-like morphology, sometimes with more myxoid stroma, sometimes with floating neurons, sometimes with more microcysts. So in many instances, everyone who sees neuropathology cases, you can definitely make a definitive diagnosis only looking at the H&E. So let's employ the most commonly used methodology for oncology in adults, which is NGS. The first case has an FGFR1 hotspot mutation. The second case has the second most common mutation of FGFR1. The third case has an alteration called FGFR1 tandem duplication, and the fourth case has the same molecular alteration of the second. So are we able to make the diagnosis based on these NGS results? And the answer is no. We need something else to make the diagnosis. But if we employ methylation profiling, even tumors with the same molecular alterations will have distinct methylation profiles. So the first case is a rosette-forming glioneuronal tumor. The second case is a pilocytic astrocytoma. The ones with FGFR1 alteration usually have this more oligodendroglioma-like morphology. The third one is a deserioplastic neuroepithelial tumor, or DNET. And the fourth one, even with methylation profiling, we can only classify as a glioneuronal tumor, not otherwise specified. So if you take the DNA from each tumor type in the CNS, we can identify that they have distinct methylation profiles and are very recurrent among the same molecular subtype. For example, most of the glioblastomas IDH wild type have the same methylation profile, which is also true for the astrocytomas IDH mutant and the ependymomas posterior fossa type B and all the other tumor types. So the methylation profile is a very useful and reliable method to make the diagnosis of certain tumor types. And especially everything started in neuropathology, especially because we have a real challenge in making the diagnosis of neuropathology. Because even if you get a maximum safe resection, the samples have a small size. We have a lot of morphologic overlap between all the tumor types. We don't have specific immunohistochemical alterations or even molecular alterations for most entities. Even if you think about a very common fusion in pilocytic astrocytoma, which is the KIA 1549 BRAF fusion, it can also be present in other tumor types, other high-grade tumor types, such as high-grade astrocytoma with pyloid features, which we call HGAP, or most diffuse leptomeningeal glioneuronal tumors with really distinct clinical implications. If you think, for example, in the most common BRAF variant, which is the V600E mutation, can be present in grade 1 tumors, such as ganglioglioma, can be present in PXAs, and also in some rare high-grade tumors, such as glioblastomas. And we have some alterations that are prognostic and diagnostic. For example, third promoter mutation, which is by WHO 5th edition, is a molecular criteria for glioblastoma IDH wild type, but which is also present in 100% of oligodendrogliomas and some other high-grade tumors, such as high-grade PXAs and also HGAPs. And other alterations such as the CDKN2A homozygous deletion, which is almost diagnostic, presenting over 90% of the PXAs, can be present in most glioblastomas and also can be only a grading criteria for IDH mutant gliomas and also a prognostic criteria for ZFTA-fused ependymomas. So we can find a really specific molecular or morphological alteration for a CNS tumor type. So we need an additional method, and the additional method that we have nowadays is the DNA methylation. So thinking in chemically, the methylation is the introduction of a methyl group, which is a CH3 in the fifth position in the cytosine ring. So we have two types of cytosine in our DNA. We have the methyl cytosine and the cytosine which is unmethylated. And this happens usually when the cytosine is linked to a guanine by a phosphate bridge, which we call, and when we have a lot of this composition, we call CPG islands. And the CPG islands are located mainly in the promoted region of genes. So if a promoted region is highly methylated and hypermethylated, the DNA polymerase can't start to transcribe the gene. So the gene is silenced. And if the promoter region is unmethylated or hypomethylated, that gene can be transcribed and active. And also the DNA, the methylation also plays a very important role in gliomagenesis and also in oncogenesis. We have several tumor types, which the main molecular mechanisms of oncogenesis is the global DNA hypomethylation. And one example of that is the diffuse midline glioma H3K27M mutant. They have a global DNA hypomethylation. Having this hypomethylation, then they have several active oncogenes. These oncogenes leads to genome instability, which leads to more proliferation and a very aggressive tumor type. And this also can occur very focally in a specific gene. So if you have a methylation of a tumor suppressor gene, that gene is going to lose their function. And if you have hypomethylation of a proto-oncogene, that oncogene will be active, and everything of this will promote cancer. So how can we use that in our clinical practice? We can use that by molecular techniques called methylation arrays. So we having several methylation arrays over time. We had the arrays with 27,000 probes, 450,000 probes, 850,000 probes, and now we have the EPIC version 2.0, which encompasses almost 1 million probes of methylation and unmethylated sites in the DNA. So we need to use that information. And for using that to diagnose tumors, we have to employ this molecular technique, and we have to get the raw data of the array, which is going to say which sites are methylated, unmethylated, or partially methylated. And we're going to need molecular classifier for these tumors, which are based in machine learning tools that are developed by several groups in the world, especially by the researchers from the Heidelberg University in Germany. So we can get this raw data that are provided by the bead chips or the EPIC arrays, and we're going to use this machine learning platform for making the diagnosis. And how does everything of this started? Everything started several years ago, but the first huge publication we had was the seminal publication in Nature in 2018 about the DNA methylation classifier of the Heidelberg University. The authors showed us how they comprised reference cohort with 91 classes of methylation composed of over 2,800 samples. So they could identify the methylation profile of several tumor types of the CNS, also for normal regions, metastasis, also for pituitary adenomas, melanomas, lymphomas, and also plasmacytomas. And then applying bioinformatics, you can aggregate and separate tumor types by the similarity of their epigenetic profiles. So this is a t-SNE plot, the stochastic neighbor embedding T distributed based on the epigenetic profiles of the first reference cohort of Heidelberg University, which had this 2,800 samples. Nowadays, the reference cohort of Heidelberg University has more than 100,000 samples. So here, looking at this graph, this picture, we can see several molecular subtypes of CNS tumors, such as medulloblastoma group 3 and group 4, medulloblastoma Wnt activated, IDH mutant tumors, ependymomas, and etc. So anytime I perform a new sample in methylation profiling, I can plot my sample in a graphic like this, but also they created a new method to diagnose tumors, which was the creation of a score, which was at the end, at the day, called calibrated score. That is a score with high sensitivity and specificity for the diagnosis of certain tumor type. And they established some cutoffs. This calibrated score ranges from 0 to 1, and if it's 0.9 or over, it's almost diagnostic of the tumor type that is indicated. And for a subclass, at least in the initial classifier, a score that 0.5 or over was very indicative of the specific tumor type. So, in order to validate these findings, they uh, studied more than 1,155 cases from other institutions, and they could perform methylation profiling in 88% of the cases. And what was very surprising was that in 12% of the cases, they could establish a new diagnosis, which was distinct from the original histopathological diagnosis. And in almost 20% of the cases, there was molecular refinement. And this usually happens with medulloblastomas and also ependymomas. So it was very shocking for the community that using a molecular method, we could have change in our initial diagnosis. So now we have to be more careful to making the diagnosis of CNS tumors. So I'm going to show a couple of cases to you that will illustrate some very classic and some other that are more rare cases. The first one was a 58 years old man with a temporal lobe tumor in the radiology, in the MRI, has a hyper intense signal in T2 weighted images with T2, T1 hypo intense images, was a diffuse lesion without any contrast enhancement. I hope there's no radiologist in the audience, and I hope I'm not saying anything wrong, but this is the lesion here in the left temporal lobe. It has a high T2 signal and a low T1 signal with no contrast enhancement. So what's supposed to be by radiology, usually they call this glio lesion, no high-grade features. And also in the pathology, we had this increase in cellularity. So we know that we are facing a diffuse glioma here, but we don't have too much atypia. The cells have this round to oval nuclei with some hyperchromasia, but we couldn't find mitotic figures, necrosis, or microvascular proliferation, which are features of a high-grade glioma. And the IHC summary was positive for glial markers. IDH1 was negative, ATRX was retained, P53 was focal, and the Ki67 was really low. So this case was submitted to NGS panel that covers 500 genes, and the only alteration that was initially found was a third primordial mutation, a classical third primordial mutation. So based on the WHO criteria, anytime we have a diffuse associated glioma, which is IDH wild type, if it has necrosis, microvascular proliferation, we are going to call this glioblastoma IDH wild type, and we are very good to making this diagnosis as pathologists. But even if the tumor doesn't have necrosis or microvascular proliferation or any anaplastic features, if it has by molecular evaluation, EGFR amplification, third primordial mutation, and the signature of gain of chromosome 7 and loss of chromosome 10, we are also allowed so far to make a diagnosis of glioblastoma IDH wild type. So as this tumor had only the third primordial mutation, the oncologist was a little bit concerned of being not facing a real glioblastoma, and then we submitted the case to DNA methylation profiling. By DNA methylation, we could find a score of match to the subclass mesenchymal of glioblastoma IDH wild type. We had several chromosomal gains and losses, and this copy number variation plot is estimated by the DNA methylation, the array of methylation. And here we can see gain of chromosome 7 and loss of chromosome 10. The MGMT primordial status was methylated, and using the NIH classifier and NIH reference cohort, we could identify that our tumor was in the cluster, a new cluster that is called diffuse glioma F3T3 outlier. And I'm going to get back to this in the next slides. So the first lesson for this case is that the prospective identification of early glioblastomas and undersampled glioblastomas lead to improved clinical outcomes because those patients need to receive glioblastoma treatment, glioblastoma type treatment, which is usually the STUP protocol. So there's one situation that we are more used to when you have a tumor that by radiology is very typical of glioblastoma. You have this hyposignal in T1, hypersignal in T2 with this ring enhancement by contrast. And usually the biopsy is going to be superficial and we're going to have only mild infiltration of the parenchyma. But if you go to molecular alterations, they will find glioblastoma IDH wild type alterations such as gain of 7, loss of 10, third promoter mutation, NF1 and PTEN inactivation. But the other situation that now we are starting to recognize even more is when we have a case like I just showed you, when the radiology is not of a high-grade tumor, is of a low-grade tumor because there's no contrast enhancement, there's no necrotic areas. In the histology, usually we only see a diffuse atrophic glioma, but by molecular evaluation, we are going to find the classical glioblastoma alterations, gain of 7, plus of 10, third promoter mutation, and EGFR amplification. So it's very important to identify this type of case. And the other lesson of this case is that we could find that our case clustered with this new cluster that's called F3T3O. And going to the initial publication from the NIH group, they discovered that a subtype of glioblastomas with FGFR3 alteration had a better outcome than other glioblastomas, and that what they call diffuse glioma F3T3O. When comparison to the regular glioblastomas, there was a significant difference in overall survival. So, but our case had performed NGS and couldn't find any other alteration. So we went back to the NGS report and we could find in the variants of unknown significance, or VUS, fusion between FGFR3 and the GRHL2 gene, which is very rare, probably undescribed, and that's why it was called VUS. But given this context, it started to make sense. And when you go to the initial NIH publication, although most of the cases had the classical FGFR3 TAC3 fusion, one case have also FGFR alteration with a more rare partner. So we can perform integrated diagnosis with all the information we could get. So this is a diffuse astrocytic glioma IDH wild type with molecular features of glioblastoma IDH wild type. By morphology is a diffuse associated glioma, but is a grade 4, and the molecular findings are the third promoter mutation, plus 10 minus 10 plus 7 minus 10 signature, methylation class glioblastoma IDH wild type, subtype mesenchymal, and NIH evaluation from the cluster F3T3O with this FGFR3 fusion classified as VUS, which may show better prognosis. This case was one of the first cases we performed methylation in Brazil, and the patient is still alive after receiving STUP protocol. A second case, which is very common to our to us pathologists, this is a male 32 years old with a frontal lobe tumor. We look at this at the morphology. There's increasing cellularity, so probably it's a glioma. We can see these brown glioma cells with these perinuclear halos and this fried egg appearance, and it's very monotonous. The cells look like exact twins, and then we all know that this very likely to be an oligodendroglioma. We're gonna use, of course, perform immunohistochemistry first, and this case was positive for IDH R132.8 mutation. ATRX was retained, P53 was negative or non-aberrant, and the Ki67 is very low. So it has morphology of oligodendroglioma, has the immunohistochemistry of oligodendroglioma, but still we have to prove the 1P and 19Q co-deletion. And we can employ several molecular methods for that, and one of them is methylation profiling. So we perform methylation in this case, and we're gonna have all the information together. We have a high calibrated score for the methylation class, IDH glioma, 1P19Q co-deleted oligodendroglioma. In the CNV plot, we can see the 1P and 19Q loss, so we have the co-deletion, and almost 100% of the oligodendrogliomas, because of the IDH mutation, are methylated for the MGMT promoter gene. So now we can make an integrated diagnosis of oligodendroglioma, IDH mutant, and 1P19Q co-deleted. In this case, we have to go back to morphology for grading, is a grade 2 based on CNS criteria. Another example, this is a patient, 42-year-old patient, known to have neurofibromatosis type 1, has several neurofibromas, and from a long time was following ill-defined thalamic tumor, but then he started to develop neurological symptoms, and they discovered the lesion was growing, and they decided to perform a biopsy of the thalamic lesion. By morphology, we can see increase in cellularity and some vascular proliferation, have increase in vascularity. Going to the the details, the cells have this enlarged and hyperchromatic nuclei with some increase in vasculature. Here we can see this a little bit like atypical cells with sparse mitotic figures. Initially, this case was called glioblastoma IDH wild type, but the clinician submitted the case in a research protocol for NGS panel, and he could find the NF1 germline mutation for this patient and a distinct combination of alterations, CDKN2A and MTAP homozygous loss, and there was a VUS in the ATRX gene. And then he sent me the NGS report, and I said, well, there's no third promoter mutation, there's no gene amplifications. Maybe this is not a GBM. Maybe this could be something else, especially based on this combination of gene alterations. So we performed a methylation profile for this case, and it had a match to the methylation class high-grade astrocytoma with pyloid features, which we call HGAP. In the copy number variation plot, as it is a high-grade tumor, we can see several gains and several losses, and also the homozygous deletion of CDKN2 A and B that we can see in this small dot in the short arm of chromosome 9. By the t-SNE clustering, it perfectly clustered with the H gaps. As you can see here, they are close to the PXA cluster, and we can see our sample here in the H gap cluster. So now we can make this integrated diagnosis of high-grade astrocytoma with pyloid features, which is already included in the CNS 5th edition, and is basically a methylation-based diagnosis. You need methylation profiling in order to make this diagnosis. So the initial publication that described this tumor type was published in 2018, initially with the name of anaplastic astrocytoma with pyloid features, but then for the WHO classification was decided to change the name to high-grade astrocytoma with pyloid features. It's a high-grade glioma with astrocytic morphology, sometimes with pyloid cytology and anaplasia. It has frequent MAP kinase alterations, together with CDKN2A and B homozygous deletion and ATRX alterations. The most common MAP kinase alterations are NF1, as in this case, BRAF and FGFR1. They are very common in the cerebellum of adult patients, and the prognosis is better than glioblastomas, although it is worse than pilocytic astrocytomas, and it is a methylation-based diagnosis. So these are pictures from the original publication. Most of the cases are located in the cerebellum, but some of them are supratentorial and even in the spinal cord. And the age, most common age is between 20 and 50 years old. So whenever you have a case in the cerebellum that looks pilocytic astrocytoma or even glioblastoma in an adult patient, remember high-grade astrocytoma with pyloid features, they can emerge as a de novo lesion, or they can be recurrence of a previously diagnosed low-grade lesion. And the most common alteration are NF1 alterations. Also, they can have the BRAF-KIA fusion, and it's very common the CDKN2A homozygous deletion. And regarding prognosis, the prognosis of HGAP is more close to the prognosis of the astrocytomas IDH mutant of high grade, which is better than glioblastoma IDH wild type. And more recently, the NIH group published this very interesting paper reclassifying gliomas in patients with neurofibromatosis type 1, because in the past, most of us believed that NF1 patients can have pilocytic astrocytomas, especially optic pathway gliomas, or glioblastomas, but this publication stated that there's a third subtype that can arise in NF1 patients, and this third subtype is the high-grade astrocytoma with pilot features, which has better prognosis than the glioblastomas that usually are from the mesenchymal subtype. And this other paper also from the NIH group, expanding the analysis of HGAPs, discovered that they could find by methylation 3 epigenetic subgroups, and one of them is enriched by NF1 patients. So whenever you have an NF1 patient with a high-grade glioma, it can be a glioblastoma, but also can be a high-grade astrocytoma with pilot features. Next case, now let's move to pediatric neuro-oncology. It's an 11-year-old girl with a mass in the posterior fossa / fourth ventricle. This case was submitted for us by a colleague pathologist, and he really had a doubt about the diagnosis because the tumor was located in the fourth ventricle and was very sharply demarcated from the surrounding parenchyma, almost with a fibrous capsule surrounding it. And by morphology, we had some small cells and some rosettes that sometimes reminds us the Romeo Wright rosettes, but he had really doubts about the rosette type, if it's Romeo Wright or ependymal rosettes. So sometimes you have this diagnostic difficulty between medulloblastomas and ependymomas in the posterior fossa. So we performed a methylation profiling. It had a match to medulloblastoma Wnt activated with a high calibrated score. It clustered in the medulloblastoma Wnt subtype, and by CNV analysis, we could see the most recurrent cytogenetic alterations of the Wnt activated subtype, which is monosomy of chromosome 6. So we can make a definitive diagnosis. A medulloblastoma Wnt activated. By morphology is a medulloblastoma with classic histopathology. It's a grade 4, has a calibrated score of 0.99 to Wnt medulloblastoma, and has this chromosome 6 monosomy. And is a medulloblastoma of very good prognosis, almost 100% of overall survival in 5 years. And there's debatable about the escalating radiation therapy for these tumor types. So we all know that we have this molecular classification for medulloblastomas, which is really important for prognosis and also for treatment. We have 4 main molecular groups, which are Wnt activated, sonic hedgehog activated, group 3 and group 4. But now we are talking even more of a second generation molecular subtyping of medulloblastomas, which is also clinically relevant. So it seems that the Wnt subtype is really something very cohesive and composed of almost only one subtype. The sonic hedgehog group, by its turn, it splits in at least 4 subtypes. We can add here the IDH mutant subtype of sonic hedgehog medulloblastomas, but we have these subclasses 1, 2, 3, and 4 of sonic hedgehog, or alpha, beta, gamma, and delta. And they have differences in the clinical presentation. For example, the subclass 3 or gamma is enriched by leaf-Romani patients with TP53 germline mutation, and the subclass 4 or delta is the most common medulloblastoma subtype in adult patients. And also this is relevant for group 3 and group 4. There's a lot of overlap between those subtypes, but we have some significant differences. So now we understand that we have at least 8 subgroups of group 3 and group 4, and by convention we consider groups 1, 2, 3, and 4 subclasses as group 3, and subclasses 5, 6, 7, 8 as group 4. And the most aggressive subclasses are subclasses 2, 3, and 5, with overall survival ranging between 50 and 60% in 5 years. And the most indolent cases are from classes 6, 7, and 8, with over 80% of overall survival in 5 years. In this very nice paper showed that it is relevant to subtype the tumors between group 3 and group 4, because group 3 has lower progression-free survival and overall survival, and also that the subgrouping is also important. Looking at the subgroups 2, 3, and 5, have the lower PFS and overall survival as well. So we can identify high-risk medulloblastoma patients and very high-risk medulloblastoma patients, even from group 3 and group 4. Next case is a 3-year-old girl with this large mass in the right ventriculum extending to the occipital lobe. By morphology, we can see is very compact, highly cellular, composed of cells with scant cytoplasm, highly cellular with mitotic figures and apoptotic bodies. So any of us pathologists can look at this in the microscope and say it's a small blue round cell tumor. And if it is in the CNS, probably this is an embryonal tumor. But we can go further right nowadays. So methylation profiling is teaching us in how to approximate the diagnosis of these tumors. And this tumor was diffusely positive for synaptophysin, which is common in embryonal tumors because they have primitive neuronal differentiation. But also this tumor is highly constant with diffuse OLIG2 and SOX10 expression. And then we perform methylation profiling, and it had a match to the neuroblastoma of the CNS, FOXR2 activated, MGMT is unmethylated. By CNV analysis, we have chromosome 1q gain and 16q loss, which is highly recurrent in this tumor type, and it clustered in a really tight cluster that's the CNS neuroblastoma FOXR2 alteration. So we can make this final diagnosis, and usually most molecular methods that are commercially available are not able to identify the FOXR2 activations of this tumor type, so we need methylation in most instances. So this is a neuroblastoma FOXR2 activated. It's already in the WHO book. By morphology, it's embryonal. It is a grade 4 tumor, has a high score for CNB FOXR2, and has the 1q gain and 16q loss. And we started to listen about these new entities from this paper from Dominic Sturm and other colleagues from Heidelberg University. They studied over 300 cases initially diagnosed as PNETs, or so-called PNETs, primitive neuroectodermal tumors. And usually, using methylation profiling, they could classify most tumors as other tumor types in the CNS, embryonal tumors, but also a lot of high-grade gliomas were called embryonal tumors, some ATRTs, Ewing sarcomas, PXAs, meningiomas, pineoblastomas, and ependymomas. But for 4 molecular clusters, they couldn't find a known tumor entity at that time. And the clusters were the high-grade neuroepithelial tumor of B-core alteration, the high-grade neuroepithelial tumor with MN1 alteration. Now we know that these are astroblastomas, the Ewing family tumors with thick rearrangement, and the neuroblastoma with FOXR2 activation. And they could identify those cases and identify the clinical and epidemiological features of these new tumor types. So the morphology of FOXR2 usually is of an embryonal tumor, sometimes with ganglionic differentiation and small blue round cells. The CIC sarcomas usually have this round cell morphology, but also can be more epithelioid with microcysts or more spindled. The high-grade neuroepithelial tumors with MN1 alterations or astroblastomas can have the classic astroblastic perivascular pseudo-rosettes and the stromal hyalinization, but also can have really high-grade features. In the tumors with B-core alteration, they usually have this ependymoma-like with perivascular pseudo-rosettes, and also can be very spindle cell in presentation. And regarding the CNS neuroblastoma FOXR2 alteration, the majority of cases are supratentorial in the hemispheric cortex, but also can be intraventricular, as our case. And usually they occur in very young patients around 6 to 7 years old. And this is the first paper that showed that the FOXR2 tumors can have diffuse OLIG2 expression, and also now we know they also can express SOX10. And it's very important because we call many things small blue round cell tumors under the microscope and primitive neuroectodermal tumors in the past. So St. Jude's Hospital decided to evaluate cases enrolled in clinical trials in the past for PNETs and perform methylation profiling for molecular classification. And the most important finding of this study is that around 50% of the cases were not primitive neuroectodermal tumors and were never intended to be enrolled in those trials. So those trials had a mix of several tumor types, especially high-grade gliomas. And the other very important finding is that when you stratify by molecular diagnosis, the CNS neuroblastoma FOXR2 alteration has the best progression-free survival and the best overall survival. And the ETMR or embryonal tumor with mutilated rosettes have the worst progression-free survival and the worst overall survival. So now we can better stratify the prognosis of our patients, make more precise diagnosis, and allow patients to be properly enrolled in proper clinical trials. So what's the experience of other groups with methylation profiling? This is the experience of NIH with over 1,000 cases that were received for diagnostic consultation. In the NIH initial experience, almost 27% of the cases received new diagnosis after methylation, and almost 20% of the cases had a refined diagnosis. So almost 50% of the cases had benefit for employing methylation profiling. Of course, that for some tumor types where you have a specific immunohistochemical marker, such as ATRT, where you can see the INI1 loss, or for diffuse midline glioma with positivity for K27M antibody. Usually you don't change the diagnosis, but whenever you have an unclassified neoplasm, any descriptive diagnosis, you're gonna find something really interesting in most instances. This is the German experience with molecular multiomic neuropathology, and they showed that stratifying cases by molecular risk is better than only by morphology. And sometimes you have a low-grade case by morphology, which is a high-grade by molecular, and the opposite is also true. And stratifying by molecular risk in low, intermediate, or high risk better stratifies patients than by morphology and not even immunohistochemistry alone. And also this is the experience from Netherlands. And what's interesting from this paper is that 22.4% of the cases were downgraded by methylation profiling, and almost 50% of the cases initially diagnosed as low-grade tumors were upgraded by methylation profiling. So we really change how the clinicians treat those patients. And this is the New York University experience, which is very similar to the Netherlands. In 22% of the high-grade descriptive diagnosis, they could find a low-grade methylation class, and in 26% of the cases initially diagnosed as low-grade tumors, they had a high-grade methylation class. So methylation class is really important to make a precise diagnosis for those patients. And they even proposed some criteria for using DNA methylation in clinical practice. And now we have a same pact now update that also brings very useful instances where we need to use methylation profiling for diagnosis. And what's our experience here in Brazil? I'm going to tell you our short story. We started in 2021. I was looking for someone that was able to perform methylation profiling, and I could find a researcher in the University of São Paulo called Leslie Kulikowski that runs a cytogenomics lab and performs several molecular testing. And then she had a 450K EPIC methylation chip, and we had some cases that I would like to test. And then we run our first batch of 8 cases. One case was diagnosed as diffuse midline glioma H3K27M mutant, but it was outside midline. The second case was diagnosed as PXA, and the initial diagnosis was ependymoma. The third case was diagnosed as diffuse hemispheric glioma H3G34 mutant. One case had a low score for pediatric high-grade glioma. nothing is perfect. And I wasn't sure if I had to include a control in the first run. In any case, I included a piece of tissue and then had a match for hemispheric cortex. We had no match in 2 cases, so was undefined. And the last case was a medulloblastoma, sonic hedgehog activated subclass 4, and was a medulloblastoma from an adult patient. After that, I moved to DASA, and then we started to validate the methylation profiling, and we started with 64 cases, and really difficult cases in our routine, and we can have score over 0.84, which was the cutoff we established in 80% of the cases. And in those cases, in 14% of that, we had a discordance between the initial diagnosis and the methylation profiling diagnosis. And plus 34% of the cases where we could refine the diagnosis, especially medulloblastomas and ependymomas. So I was intrigued, was it the cause of not having a match score for a certain tumor type? In most instances, unfortunately in Brazil, we have several issues with pre-analytical factors, especially, but not using buffered formalin for fixation. And then in most cases, we had poor DNA quality. But for one case, we had a new entity that was not included in the Heidelberg classifier and still not included, but is present in the NIH classifier, which is the intracranial mesenchymal tubule fat crab fusion positive. So now we can look for the fusion, we can look for FISH for EWSR1, or we can run the case in the NIH classifier. So this is the issue. We're going to extract DNA as any other molecular testing from the paraffin block. So we're going to section several unstained slides and select the tumor area and do some scrapes for DNA extraction. And the great problem, especially here in Brazil and probably in some other countries, is that we have 2 types of formalin available in the market. One which has a pH of 3, 4, which is acid and degrades DNA, and the other one which is buffered formalin. And the only formalin that's suitable for anatomic pathology is buffer formalin, so I need to mention this. And the other issue that we could have is the cellularity. Sometimes the cellularity of the tumor is really low, especially in the diffuse infiltrative areas of gliomas. And the more cellularity you have, the more the probability of having a good score. So this is a study from the Northwestern University and New York University, and both could find that they estimated that when you have at least 60% of tumor cellularity, you're going to have more high scores. And when you have less than 60%, sometimes you can get high scores, but usually you're going to have scores below the threshold for tumor diagnosis. After the validation, we then started to employ methylation profiling in our routine diagnosis since January 2023. And since then, we already performed methylation in 476 consecutive patients. And for all cases, we performed the histopathological immunohistochemical review, and we integrate with the methylation and the CNV data in order to provide an integrated diagnosis as is recommended by WHO. And we also compare and take note between the difference between the initial diagnosis and the integrated diagnosis. And for each discordant case, we take note if it was discordant by a distinct tumor type, or if it was a distinct lineage, or if it was only a grading change. So the most frequent diagnosis that we have follows the epidemiology of the most common brain tumor types, and then we have a cohort that is enriched for adult patients. So we have a lot of glioblastomas, IDH wild types, also astrocytomas, IDH mutants, and oligodendrogliomas, IDH mutants, and 1p19q co-deleted. So the most common and the 3 main tumor types of the diffuse gliomas in adult patients in the WHO book are represented in our cohort. And of course, we also have some pediatric cases. We have several pilocytic astrocytomas and pediatric type high-grade gliomas, IDH and H3 wild type. And of course, some meningiomas. There's an increasing role of methylation profiling for better stratifying and grading for meningiomas. We are able also to refine the diagnosis of several tumor types, especially ependymomas and medulloblastomas. We are able to identify the tumors from posterior fossa groups A and B, supratentorial ZFTA fusion, spinal cord, and also for medulloblastomas, we have cases for most molecular subclasses. And only by methylation, we are able to make really rare diagnoses when sometimes you can have a specific NGS alteration, or sometimes you have a specific molecular alteration but can be missed by some commercial available NGS testing. For example, the new entity called high-grade glioma with pleomorphic and pseudopapillary features, or HPAP, which has been described by NIH group. Also the HGAP that I've already showed you, and also the tumor with PET-C1 alteration, B-core alteration, fat crab fusion, FOXR2 alteration, and several other really rare tumor types that we are only able to make the diagnosis because of methylation profiling. Regarding the diagnostic concordance in our cohort, in 25.6% of the cases, we had a diagnostic change. This is closer to the NIH experience, which is almost 27%, because the composition of our cohort is more similar to the composition of the NIH cohort in their publication, which are cases with really difficulties in common histopathological diagnosis. And we have confirmation in 70% of the cases. We have several distinct alterations. For example, one case that was diagnosed as angiosarcoma was a recurrence after several courses of radiation therapy and was diagnosed as oligosarcoma. Most cases diagnosed as diffuse gliomas fall in several different tumor types, such as DNET, astrocytoma IDH mutant, subtype F of adult type high-grade glioma, and many glioblastomas. And we also change cases that has the diagnosis of low-grade glioneoplasms to high-grade glioneoplasms or glioneuronal neoplasms. Some cases that are diagnosed as ependymoneoplasms are in fact high-grade glioneoplasms, and some cases that are high-grade glio are embryonal or low-grade or glioneuronal. So we have several really clinically relevant diagnostic changes. These are the last example from this consecutive cohort was a 15-year-old teenager with this left frontal T2 hyperintense lesion with irregular contrast enhancement. And by morphology, most of the pathologists would look at this case and see this is a small blue round cell tumor, and this is probably embryonal tumor, so-called primitive neuroectodermal tumor, or PNET. But remember the PNET paper, in this case, was submitted to methylation, and in fact, it was a glioblastoma IDH wild type with a primitive neuronal component, which we have been diagnosed for several times by morphology and immunohistochemistry, and now we understand that it comprises a specific cluster by methylation profiling. So the treatment of a high-grade glioma is completely different from an embryonal tumor, and this patient didn't had a response to the initial embryonal tumor type treatment. And this specific methylation cluster that was published in Acta Neuropathologica in 2021, where you can see they usually have this small cell appearance, and usually they have p53, RB1, and PTEN alterations, and they comprise a specific cluster of glioblastomas close to other glioblastomas, so they need treatment of high-grade gliomas. And remember again this paper, whenever you have a PNET by morphology in IHC, we need to go further because many of them will not turn out to be PNETs, to be embryonal tumors, but other tumor types. And even if they are embryonal tumors, we need to know the specific tumor type that they are, because they have completely distinct prognosis and then evaluation. This is the evaluation of the CNS FOXR2, which I've already showed you. And this is the importance of stratifying by molecular diagnosis the embryonal tumors of the CNS. They have very different behavior and clinical evolution. So to summarize, DNA methylation profiling is a powerful tool in the diagnostic setting for difficult diagnosis, for uncommon presentations, for recognizing new entities, and for research. And I really like what Dr. Marta Quezado from NIH always says, that DNA methylation by itself is not a diagnostician. The pathologist is the diagnostician that uses methylation profiling to make a better diagnosis. So we need to understand what are the potential of this new molecular technique. Its use is already well established for CNS tumors, and also for sarcomas. We have the version 13.1 of the sarcoma classifier in the Epignostics Heidelberg website. So it has several tumor types, new sarcoma types, and can also be used. And also we can have an applications for methylation profiling for classifying neuroblastomas, for sinonasal tumors, and a growing list of tumor types and applications. So now we as pathologists and also the biologists, bioinformaticians, oncologists, radiation oncologists, neurosurgeons, everyone involved in neuro-oncology needs to be able to integrate and interpret multiomic findings, including methylation profiling, to achieve a precise diagnosis and also to provide more proper treatment for our patients. By saying that, I once again say thank you very much to every one of you that are watching us live and is going to watch us later on YouTube. And thank you, Rifat, for all your support and for giving this opportunity to talk about methylation and neuropathology, and also for opening the doors of Pathcast for the Latin American speakers and for Latin American audience. Thank you so much, and I'm happy to take any questions. Obrigado.
Thank you so much, Dr. Dalmeida. This was amazing. And there are quite a few questions from our audience on both Facebook and YouTube. Let me read them to you. So one of our colleague from South Africa who is watching, so has this question for you, that who thanks you for the presentation and says, so according to WHO, how would we classify a diffuse astrocytoma IDH wild type which does not have necrosis or mitotic activity, no EGFR or TART alterations?
All right, thank you so much for this question. It's a very common question because it's a very common situation we face in neuropathology. So the most important thing that most of us need to understand in the past, and also when I learned in pathology residency, we had these three terminologies: diffuse astrocytoma, anaplastic astrocytoma, and glioblastoma. And we need to understand that the terminologies diffuse astrocytoma and anaplastic astrocytoma are not used anymore. So because most of the so-called diffuse astrocytomas and anaplastic astrocytomas, IDH wild types, will have molecular alterations of glioblastoma IDH wild type. So we need to forget that old terminology. And if you face a situation when you have a diffuse astrocytoma, diffuse glioma with astrocytic morphology, which is IDH wild type and does not fulfill criteria for glioblastoma IDH wild type, it is better to make a descriptive diagnosis of diffuse astrocytic glioma not otherwise specified. And if you have the opportunity to perform methylation profiling in a case like that, I think you're going to have a lot of benefit because some of those cases will fall in really new methylation classes. For example, diffuse glioneuronal tumor with oligodendroglioma-like features in nuclear clusters, or DGONC, they can present as diffuse infiltrative astrocytic gliomas. They will be IDH wild type, and they will not have any other molecular alteration that can be detected by NGS panel. So my recommendation, be descriptive. Do not use the terminology diffuse astrocytoma. Be descriptive and recognize we cannot go further in that situation. It's a diffuse astrocytic glioma. I can't see high grade, or I can't see microvascular proliferation, necrosis, I can see mitotic figures. But in any case, it still can be a high grade tumor. It will depend on the conjunction of molecular testing. That's why methylation profiling is going to be useful in a case like this.
Right, thank you. And I think from our same viewer who wanted to add this question to the previous one, most likely you already answered it. The question was, can I call something astrocytoma IDH wild type?
Well, I wouldn't do that. I would not use that terminology, of course. We have several types of reporting in pathology. I prefer to use a more descriptive term because astrocytoma um, maybe makes a confusion with astrocytoma IDH mutant or a confusion with other tumor that had the name astrocytoma. So probably using diffuse astrocytic neoplasm, not otherwise specified, would avoid confusion in the surgeon and in the oncologist. So I would be more descriptive, and I would recommend in a comment what molecular methods are necessary to complement that diagnosis.
Thank you, Dr. Dalmeda. There is another question I will read out to you. So I think this is this I was going to ask anyway, but someone has already asked. So this question is, in some countries or institutions where methylation testing is not available due to financial constraints, GBM may present with features resembling grade 2-3 astrocytoma without necrosis or microvascular proliferation. However, when EGFR is positive 7 to 10 and TART testings are performed, so the tumor would instead fall into grade 4. So I'm wondering how such situations should best be managed. Could it be that this is not a major concern in practice, since such cases may be relatively uncommon? I would greatly appreciate your recommendation. Yeah, sorry if I was too long.
Don't worry. Oh, thank you so much for the question and also for the comments. Yes, we still are learning with those cases, but the evidence we have so far is if you have molecular features of glioblastoma IDH wild type, in most of the cases, the clinical behavior will be as a glioblastoma IDH wild type. Of course, for some specific cases without any high-grade feature and with with morphological features that would be classified in the past as grade 2, maybe some of those cases, especially without gene amplifications, may have a more indolent behavior, but they still need to receive the GBM-like treatment. That's the evidence we have so far. So if it has high-grade molecular features, and if you are not comfortable calling that straight glioblastoma IDH wild type, you can always use the phrasing diffuse astrocytic glioma with molecular features of glioblastoma or with high-grade molecular features. So they will understand and they will know what to do with the patient, which is chemotherapy with temozolomide and radiation therapy. And probably this will be beneficial for the patient instead of doing what we did in the past, calling astrocytoma grade 2, and in some instances, then would only observe the patient or give only radiation therapy. And 3 to 6 months later, the tumor would explode because molecularly was a glioblastoma. So I would use that type of phrasing, diffuse astrocytic glioma with molecular features of glioblastoma. You can always say in a comment that although there's no high-grade morphological features based on WHO criteria, this tumor molecularly has features of glioblastoma IDH wild type. But of course, we still are learning and probably maybe from some years from now, we would better understand what's the significance of these morphological grade 2 but molecular grade 4 tumors.
Thank you. There is another question from our colleague Marco from Mexico City. So who says methylation profiling is a perfect diagnostic tool. That is correct. Have you ever had a discordance result with morphology, which might have affected clinical outcome?
Well, Marco, thank you again for your participation and for your question. Well, the main message is there's no perfect tool and there's no magic bullet. We, as pathologists, we are in the center of the integrated diagnosis. Sometimes methylation does not provide you a specific methylation class. We have some 6 to 8% of inconclusive cases. And we have some cases where methylation profiling is misleading. So we need to go back to morphology, immunohistochemistry, even radiology, and who makes the integrated diagnosis is not the methylation array, is the neuropathologist or is the pathologist. So we have several discordances again with morphology. As I showed you, almost 26% of the cases we have discordance. In most of these discordances, methylation profiling is right, especially when the array is well performed, the quality controls are working good. Methylation profiling is the best diagnosis. So I really rely on this method by the literature and by my personal experience. But of course, there's no single perfect diagnostic tool. The best diagnostic tool is to integrate, and the pathologist needs to play a role in this setting.
Thank you again. So there is a question from Kalyani from India, who wants to know if if you have any experience about methylation profiling in soft tissue tumors.
All right, Kalyani is a very good friend from social media from more than 10 years, and good to see you here and good to have your question. I do have some experience with soft tissues and specific the previous sarcoma classifier, which was version 12. I didn't have too many tumor sarcoma types, but now with version 13, we have more tumor types and it's more precise. So I think that in many cases can be very helpful, especially for some fusion-driven sarcomas where the RNA sequencing failed, or for example, CIC, rearranged sarcomas, where in many instances, Archer panels or RNA sequencing can miss the seq Dux fusion, and it perform methylation profiling as DNA is more stable and more constant. In many instances, you can identify the methylation profiling of these fusion-driven tumors. So I think it's helpful in many situations. It's not helpful in sarcomas that are very pleomorphic and are very inflamed, when they have a really stromal inflammatory reaction, because the DNA of the inflammatory cells can influence in the tumor DNA, and in many instances we can have some score for inflammatory myofibroblastic tumor, but you can see it's a high-grade pleomorphic sarcoma just with necrosis and inflammation. So we need to be careful, but for fusion-driven sarcomas, I really think it's helpful.
One last question. Our colleague Alexei is sending greetings from Ukraine, and he wants to know, how do you see the application of NGS? Is it appropriate for every tumor, or should there be clear selection criteria?
All right. Thank you so much, Alexei from Ukraine. And I hope everything is good with you over there. And that's a 1 million question. If I need a molecular testing and I have available NGS and I have methylation, which one should I perform first? And there's no straight answer. In my approach, I would perform methylation first if there's uncertainty regarding the diagnosis. And methylation can give you a result that will trigger a very specific molecular testing without more expensive panels. So, but in the other hand, if the diagnosis is certain and what the clinician wants is to find a therapeutic target for that patient, for example, NTRK fusion or BRAF mutation, and so the NGS will be would be very helpful. But especially now, we understand that several tumor types doesn't have a specific molecular alteration. So the short answer is try to understand what's the need for that case and what's the need of the clinician. If the main response they want is what's the diagnosis, I need to know the diagnosis. So the best method for sure is methylation profiling. But if the answer they need is I need a target for this patient because I don't have doubt about the diagnosis, so let's perform next generation sequencing. But everything is case by case discussion.
Thank you so much again, Dr. Dalmeida. This was amazing, and you have discussed in depth about methylation profiling of CNS tumors, and you have taken time to interact with our colleagues, and we really appreciate it. And as you know that our colleagues have joined from so many different countries, and we made sure that many of your colleagues and residents joined from AC Camargo Cancer Center. They said hello to you. And we also had colleagues joining from different parts of Brazil, colleagues joined from Quebec in Canada, Mexico, South Africa, as well as Ukraine, as they have asked questions. And thanks to our viewers for your support and watching our lectures. And you can always follow Patcast on our social media platforms on Facebook, YouTube, Instagram, and X. And you can stay updated with our lectures, which are always free for all of you. And as you know that we have started a Latin American lecture series, thanks to again Dr. Dalmeida, who is helping us in organizing this lecture series in both Spanish and Portuguese. And our next lecture is in Spanish. And our speaker is Dr. Fausto Rodriguez, who has delivered a lot of lectures on Patcast. Actually, he has delivered more than 20 lectures so far in English. But this time he is going to give a lecture in Spanish, and he is going to talk on gliomas. So maybe Dr. Dalmeida can help us in explaining the title better for our audience than me. So please, you can help.
Yeah, I'm pretty sure it's going to be a great lecture. Yeah, Fausto is one of the best neuropathologists in the world, as you well know. And in this lecture, he will say that navigating gliomas, the patterns, and focus beyond molecular testing. So I'm pretty sure it's going to be a great lecture, and please don't miss it next Tuesday. Two Tuesdays from here right now, or next Tuesday? Next Tuesday, yes.
Yeah.
At the same time, we will be waiting for you here at Podcast.
Thank you. Thank you so much. See you again. Thank you again, Dr. Dalmeida. We appreciate it.